Welcome to the channel, What Does Science Say? And welcome to The Deep Dive. Today, we're tackling a condition that, well, people have noticed for a really long time, centuries even, but how we understand it and definitely how we treat it has changed quite a bit. We're talking about varicocele. I think varicose veins, maybe, but in the scrotum.
Exactly. And we've got this stack of sources you sent over, some really old medical texts, modern research papers, clinical notes, the whole gamut. It maps out this journey, how
Yeah.
we figured out what varicocele is, why it happens, the impact it can have, and crucially, how doctors approach it now.
Right. So our mission today, just for you listening, is to wade through all this stuff. We want to pull out the really key bits, understand this condition from, well, way back when to today's high-tech treatments. Basically make sense of what the science says now about spotting it and managing it. Cut through the noise. Okay, let's dive in and unpack this.
Sounds good. So first things first, what is a varicocele? Essentially, it's when the veins inside the scrotum get abnormally large. Specifically, it's the network draining the testicle called the pampiniform plexus. And yeah, you're right, it's a lot like varicose veins in the legs, structurally speaking.
And the sources mention something pretty interesting about where they usually show up, don't they?
Oh, absolutely. It's quite striking, actually. They're overwhelmingly found on the left side. We're talking like 95% of cases, according to this material.
95%. Wow.
They can happen on both sides, sure, but the left side is just way more common.
So what might someone actually, see or feel?
Well, if it's big enough, yeah, you might see or feel this sort of swelling of twisted veins, usually above the testicle. Doctors can often feel it's palpable. And the classic description you hear feels like a bag of worms.
Okay. Yeah, that's descriptive. So why? Why this plumbing issue and why more on the left?
The main theory really centers on the valves inside those veins in the spermatic cord. Think of them like tiny one-way gates for blood flow. They're supposed to stop blood flowing backwards. If those valves fail, if they become incompetent, blood can pool up, flow backward.
Reflux, right.
Exactly, reflux.
Right.
And that pooling blood increases pressure, causing the veins to stretch out, dilate.
And the sources link that valve failure to specific things, like the left side thing?
Yeah, anatomy seems to be a big part of it. The way the left testicular vein joins the kidney vein, the left renal vein is at a sharp angle, almost 90 degrees. The right side drains more directly into the big vein, the vena cava. So that angle on the left might create higher pressure, making valve failure more likely there.
Ah, okay. That makes sense.
And other factors are mentioned too, like things that increase pressure in the abdomen, maybe prolonged standing, heavy lifting. Some research is looking into hormonal links too, but the valve mechanics, especially on the left, that's usually seen as the primary driver.
It's just wild thinking people noticed this centuries ago, way before we knew about valves and blood pressure like this. Let's talk about the history a bit.
You're right. I mean, men probably noticed these swollen veins as soon as we started walking upright.
Right.
Gravity and all that.
Yeah, and I was really struck by some of the ancient descriptions. Celsus, 1st century AD. He actually credits the Greeks before him, but then he adds his own observation. The veins are swollen and twisted over the testicle, which becomes smaller. He even distinguished between surface and deep veins. That's incredible detail for almost 2,000 years ago.
It really is phenomenal. It shows that he could see it, describe it, even connect it to the testicle shrinking atrophy. But from there, the history of treating it, well, let's just say it gets a bit rough.
Rough.
Yeah, a long period of trial and error, often pretty brutal. The sources describe things that sound awful today, like using hot iron's cautery to basically burn the veins shut, or various clamps, Cooper's clamp, King's clamp, all these devices named after surgeons. There was even this technique Vidal's using silver wires threaded through and tightened over time to try and make the veins ulcerate and close off, sometimes through a hole in the scrotum.
Good grief.
Yeah. And unsurprisingly, some attempts, as one source notes by Jacques-Mathieu Delpech, ended in tragedy.
That really puts things in perspective. So when did we move towards something more evidence-based, less medieval?
A key moment seems to be W.S. Tulloch's report in 1952.
Yeah.
That paper was a big deal because it wasn't just about fixing the discomfort. It really highlighted the potential link between varicocele and other problems.
Specifically infertility.
Exactly. Male infertility. That really shifted the focus.
And that link drove a lot of the innovation from the mid-century onwards.
Totally. From about the 1970s to 2000, there's this huge focus on varicocelectomy, the surgery specifically for treating infertility. That spurred all sorts of new ideas, bringing in radiology, minimally invasive techniques. We moved from those older open surgeries,
Yeah.
like the ones Ivanisevic or Palomo described, targeting veins higher up, towards the kinds of things we do today, like microsurgery and embolization.
Okay, let's fast forward back to now. What symptoms might someone actually have? Is it always obvious?
Well, the sources are pretty clear on this. Often there are zero symptoms, nothing at all. A
No.
lot of guys find out they have one during a routine checkup or, if they're being checked for something else entirely.
But if there are
The
symptoms?
most common one is this kind of dull, aching pain, usually in the scrotum, maybe radiating to the groin. You can feel worse after being on your feet all day or after exercise, especially lifting heavy things.
Okay.
But it's important, and the sources stress this, that pain isn't exclusive to varicocele. It could be a hernia, kidney stones, an infection.
Right, so you need a proper diagnosis.
Definitely. Rule out the other possibilities.
And beyond pain, what are the main complications we should know about?
The big one, the one that gets discussed most, is infertility. It's actually considered a top treatable cause of male infertility. The thinking, like we touched on, is that the pooled blood might raise the temperature locally. Testicles need to be slightly cooler than body temp for optimal function.
Right, for sperm production.
Exactly. And the blood just sitting there, stasis, might also mess with hormone production and the sperm themselves. Lower count, poor movement, abnormal shapes, that kind of thing.
And you mentioned testicular atrophy earlier, the shrinking.
Yes, that's another key complication, especially if a varicocele develops when a guy is a teenager, before the testicle is fully developed. The affected one might end up smaller and softer than the other. That's atrophy. And that itself can impact future fertility.
Any other potential issues mentioned?
There was a brief mention in one source about a possible, though not really proven, link to erectile dysfunction. But really, infertility and atrophy are the main concerns highlighted.
So how do doctors actually confirm it's a varicocele and, assess how bad it is?
It usually starts with a physical exam.
Mm.
The doctor can often feel the veins, especially if you're standing up. But the real key diagnostic tool these days is imaging, specifically Doppler ultrasonography.
Ultrasound, what does that show them?
It's super useful. It lets them actually see the veins, measure how wide they are. Often over 3 millimeters is considered significant. They can also measure the testicle size, check for that atrophy we talked about. And really importantly, the Doppler part lets them see blood flow specifically. If blood is flowing backward, that reflux, especially when you do something like bear down, the Valsalva maneuver.
Okay.
Oh, and one source had a practical note based on their experience. Sometimes getting a second ultrasound before jumping to treatment might be worthwhile, just because results can vary a bit.
Good tip. So once it's diagnosed, does everyone need treatment?
No, definitely not. It really depends on whether it's causing problems. The consensus in the sources is that treatment is generally considered if it's causing significant pain, if there's clear evidence of testicular atrophy, or if it's thought to be a factor in infertility. Maybe also if you're planning fertility treatments down the line. But if you have no symptoms, no pain, no fertility issues, then often just monitoring it is perfectly fine. No treatment needed.
Okay. But if treatment is the way to go, what are the modern options? What did the sources describe?
They basically fall into two main camps: surgery and radiology-based interventions. Surgically, the main idea is ligation, tying off those dilated problematic veins. This forces the blood to reroute through the healthy veins that are still working properly.
And how do they do that ligation?
Well, there's open surgery, which involves a small cut, usually in the groin. And within open surgery, the technique that gets highlighted a lot, especially for infertility, is microsurgery.
Microsurgery, using a microscope.
Exactly. It lets the surgeon see everything magnified really clearly. The big advantage is they can very carefully identify and tie off only the swollen veins while meticulously preserving the tiny testicular artery and the lymphatic vessels. Those are crucial to leave intact.
Ah, preserving the important stuff.
Precisely. That precision is why it's often called the gold standard for infertility cases. It tends to have better success rates for improving sperm quality and lower risks of complications, like the varicocele coming back, compared to some older or less precise methods. These techniques build on that historical knowledge, like from Ivanisevic and Palomo, but with much finer tools.
Is there a keyhole surgery option, too?
Yes, laparoscopic surgery. That uses a few small cuts in the abdomen with a camera and instruments inserted. It's definitely minimally invasive, though some sources noted it can be more expensive and maybe not always significantly less invasive or faster recovery-wise than a really well-done microsurgical repair through a small incision. And it usually needs general anesthesia.
Okay, so that's surgery. What about the non-surgical route?
That would be the radiologic approach, usually called embolization. This is done by an interventional radiologist, not a surgeon. Instead of cutting, they use a thin tube, a catheter, inserted typically into a large vein in your groin or maybe your neck.
Through a vein? Okay.
Yeah. Then, using X-ray guidance, they navigate that catheter right up into the problem veins in the scrotum. Once they're in position, they inject something to block the vein off.
Block it. With what?
Could be tiny metal coils, or sometimes a special liquid or foam, a sclerosing agent like alcohol or polidocanol that basically makes the veins scar shut from the inside. It's usually outpatient, sometimes just local anesthetic, so definitely less invasive up front.
But are there downsides?
The sources suggest a few potential ones compared to microsurgery. Maybe slightly less effective sometimes for improving sperm counts, potentially more costly depending on the coils or agents used, and possibly a higher chance of the varicocele returning later. There's also the X-ray exposure, but the sources mention that with modern tech, it's often comparable to other diagnostic procedures. Oh, and they also mentioned something called antegrade sclerotherapy. Similar idea, injecting a sclerosing agent, but acts as via a small cut near the scrotum base.
Seems like there's always something new. Any other techniques emerging?
Yeah, robotic surgery is making an appearance. Robot-assisted varicocelectomy using systems like the Da Vinci. There are studies out there for adults and kids. Some show similar operating times and complication rates to standard microsurgery. But the cost is significantly higher. One pediatric study mentioned in the sources put it at nearly double the cost of microsurgery. So it's technologically advanced, but that cost factor is a big consideration right now.
Right. Okay, so let's say someone has one of these procedures. What's recovery like?
Generally, it's outpatient, so you go home the same day. You should expect some soreness, maybe a dull ache in the groin area. That could last on and off for maybe 3 to 6 weeks. Bruising, swelling, that's pretty common in the scrotum and groin area, usually settles down over 3 or 4 weeks. You might feel tender down there for a bit longer, maybe up to 6 weeks or so.
And getting back to normal life activities.
Rest is important initially, but gentle movement is good too. Walking daily is usually encouraged, helps blood flow, prevents other issues, like constipation, actually. That's apparently quite common after this surgery.
Really, a constipation?
Yeah, probably due to anesthesia, pain meds, less activity. And you really want to avoid straining, because that puts pressure on the surgical site.
Makes sense.
So definitely avoid heavy lifting. The usual advice is nothing over 10 pounds and strenuous exercise for probably 2 to 3 weeks, or whatever your doctor advises.
Showers, baths, work.
Showering is usually okay the next day. But no soaking, no baths, hot tubs for about 2 weeks typically. Back to work often depends on the job. Desk job, maybe 2-3 days. Physically demanding job, could be closer to 2 weeks. And things like driving, sex, definitely ask your doctor for specific timing on those.
Okay, and back to the constipation point, the sources mentioned managing that.
Yes, they specifically highlighted it. Recommended things like increasing fiber, foods like beans, leafy greens, oats, drinking lots of water, and maybe using a stool softener or a mild laxative if needed, just to avoid that straining.
That brings up diet more broadly. Beyond recovery, can what you eat actually affect varicoceles?
Well, the sources are pretty clear that diet isn't seen as a direct cause or cure for varicocele itself, except maybe indirectly, by helping avoid chronic constipation.
But is there any other connection, like vein health generally?
There's some interesting research emerging, looking more at inflammation and overall vascular health. The idea is that inflammation might play a role in how varicoceles develop and how they impact fertility. So dietary patterns are being looked at. The sources contrasted the typical Western diet, lots of processed stuff, red meat, saturated fats, low fiber, which is linked to inflammation and oxidative stress.
Oxidative stress, damage from unstable molecules. Right?
Exactly. And that diet's also linked to obesity, hormone issues, maybe infertility. They contrasted that with something like the Mediterranean diet,
Which is
richer in things like olive oil, fish, nuts, fruits, vegetables, lots of fiber, antioxidants, healthy fats. Potentially protective against inflammation. Some studies, mostly in labs or animals so far, have looked at specific nutrients or compounds, nutraceuticals.
like vitamins or supplements.
Yeah, things like vitamin C, D, E, CoQ10, L-carnitine, minerals like selenium, zinc, magnesium, even plant extracts like essence from horse chestnut. They show some anti-inflammatory or antioxidant promise in those early studies. But, and this is big book, the sources really emphasize that we need more good human studies, especially proper clinical trials, to know if taking these things actually helps people with varicoceles or related fertility issues.
So no magic bullet food or supplement yet.
Not based on this evidence, no. focus on overall healthy eating patterns seems more relevant for now.
Which leads to prevention. Can you actually prevent getting a varicose?
Since we don't fully understand exactly why those valves fail in some guys and not others, the sources basically say there's no guaranteed way to prevent them. However, they do list some general lifestyle things that might help reduce risk or maybe slow progression and are just good for vascular health anyway. Like things like trying to avoid standing or sitting still for super long periods if you can help it. Maybe limiting excessive heat exposure down there, think frequent saunas, maybe laptops directly on the lab for hours. Wearing supportive underwear might help some people. And just general healthy lifestyle stuff. Regular exercise, balanced diet for overall blood vessel health. But no guarantees.
Okay. Let's circle back one more time to the fertility connection. It's such a major theme.
It really is. And the sources consistently identify it as a leading treatable cause of male infertility. The mechanisms, as we've said, likely involve that increased heat around the testicle and the effects of blood pooling the stasis, interfering with how sperm and hormones are produced.
Lower counts, less movement, odd shapes.
Exactly. Those are the common findings in semen analysis.
But crucially, not everyone with a varicocele is infertile.
That's a critical point, yes.
Yeah.
The sources are very clear. Many men have varicoceles and have perfectly normal fertility. Only about 15–20% of men who actually seek medical help for a varicocele are doing so because of fertility problems.
Right.
And even if treatment is done for infertility, while it often improves sperm numbers or quality, it's not a 100% guarantee for everyone. Outcomes vary.
So when is treatment usually recommended specifically for fertility reasons?
Typically, it's when you have the combination. A diagnosed varicocele plus documented problems with sperm parameters on a semen test. The decision gets stronger if the ultrasound shows significant vein swelling or blood backflow, or if the testicle on that side is smaller.
Atrophy again.
Yes. And sometimes it might be considered if a couple has tried assisted reproduction, like IVF, and it hasn't worked, and sperm issues are suspected as a contributing factor. Oh, and one last thing on treatment, the sources do mention recurrence. Varicocele can sometimes come back even after successful surgery or embolization. Why that happens can depend on various factors.
Wow. Okay. We've covered a huge amount of ground here. From, ancient Greeks noticing swollen veins and smaller testicles, through that really tough history of early treatments, right up to Doppler ultrasounds, microsurgery, embolization today, plus the impact, especially on fertility, recovery, lifestyle stuff. It's a lot.
It really is a fascinating story through medicine and biology. I think the big takeaway from all these sources is that varicocele is super common, known for millennia. Yeah. And while often harmless, it's definitely a key player in male reproductive health, particularly infertility. And our ability to diagnose and treat it effectively has just exploded, really. Understanding what it is, how it works, and what the options are, that's incredibly valuable if this is something affecting you or someone you care about.
Absolutely. And maybe a final thought for you, our listener, to chew on as we wrap up. Think about Celsus, 2,000 years ago, seeing those swollen veins, noticing the smaller testicle. Then think about our modern understanding, blood flow, temperature, inflammation, sperm health at a microscopic level. How much of the core problem is just a constant part of being human? And how much has the real revolution been in our ability to see and intervene, our tools, our knowledge? Has that changed the game more than the underlying condition itself? Something to ponder. Subscribe to the What Does Science Say channel. Don't forget to like and share your comments with us in the comment section and send it to your loved ones so they can benefit too.